Thank you, Cha, and good evening, good morning, good afternoon to everyone. And I really happy to talking about what I have learned over the last 2 decades related to the health informations and the finance and the health system, the health service system. I will starting with this. This is when General Secretariat visit Thailand for I think 3 years ago after or during COVID, and he just has a keynote, and he praised Thailand that Thailand universal health coverage can be the world model for the other countries. Do you believe that? And we are very proud. Many people, the government are always both about our success on implementing the universal health coverage. And actually, before it implemented in 2002, there is a long history. And this is just the graph that I get from the review paper that the advocacy of the UHC in Thailand right to the Lancet. And this is show that the progression of the becoming more and more universal coverage, healthcare coverage. The one indicator is the under 5 mortality rate. It become less and less. And you can see that the timeline, there is a lot of development, right? Into around 70s, there is a law that mandatory for the new doctor, the new graduate to work in the rural area. And then in 80s, the country is starting implemented civil servant medical beneficiary scheme, and also has some kind of the safety net for the poor. The younger age less than 12 and the older age of more than 60 also have free service paid by the government. At that time, that they still the budgetary system is still like the go to the hospital, go to the MOH and go to the hospital, and then provide both provide service to the people. For the people who don't have insurance like the civil servant, they will have to pay out of pocket. And then in 90, the country is starting to implement the social health insurance. This time they have the official, formal workers in the office, in the company, pay the premium. The government also adding some premium, and the employer adding to the fund. So it's social security scheme or fund. But even this, still like maybe 10 million, 14 million people still don't have the insurance because of they are not formal employee in the company. Then in 2000, after the Tom Yam Kung Asian crisis in 1997, the country just have a new government, and then the reformists in the Ministry of Health proposed that we can use the social security insurance model to expand to everyone in the country, Thai citizen, and then that become the universal health coverage scheme. So right now you can see that we have 3 schemes, right? The civil servant, the social security, and universal health coverage for all. Right now we can say that 99.9% of the Thai citizen will be covered by all of this. And many the Thai government also very always boast about the success of our universal health coverage. We am too, but it not success without any problems, and I will show you that. In 2011, that is the 10th anniversary of the universal health coverage. They kind of doing a big conference and also do a research. I also commissioned one research on the. I would like to answer that what happened before implement universal health coverage and what the impact of the current health information system in the country at that time impact the implementation of the universal health coverage. And at the same time, I would like to know that what happened after we implement universal health coverage will affect or impact the development of health information system. I do this report to the National Health Security Office and presented some of these in the conference. So what I found is that before we implement UHC in 2002, the past 10 or 15 years, we already have some kind of some infrastructure. One thing is that we have is the computerized civil registry and citizen ID, the integration of these two systems since 1986. So we are kind of have the way to identify who is a Thai citizen and who are you or something like that, and then that we can assign which insurance scheme that they will be under those insurance scheme. The second thing is that in 70, 80, and 90, hospitals and health center in Thailand has adopt using computers. So the people, the health provider just kind of export to the computer and just understand or learning to use the computer at that time in the PC. And between 80 and 90, especially in 1996, 1992, we the Ministry of Health just announced the standard for the reporting system, the standard data set for the reporting system. We implement ICD-10 for summarize report to the government to do the statistic. So in 1993, since Thailand is just is the first 3 countries in the world that implements ICD-10 in the world. And at the time, the health provider just learning to know the coder. We produce the coder and they learn about the ICD-10. And also like I said, the researcher research about the financing model, the DRG technology or the algorithms that Dr. Suprasit, which is the father of the Thai DRG, at that time he just graduated from the UK and then do the research and implemented in several schemes. So this is all the factors that make it that it's possible for Thailand to implement UHC after there is a political will and the politics say that they will create the law to get the universal health coverage. So it not happen because of the politics only, but we already have some some asset that can be implement universal health coverage within 1 year. So we can implement within 1 year. And at the same time, after that, after implement universal health coverage, is the universal health coverage also impact the development of the health information system and health IT in the countries. One thing is that because of the citizen ID and CRVS registry that cover all every people in the country, then we can identify beneficiary of the health of each insurance very accurate. So this in turn improve the civil registration and vital statistics system too, because if you have citizen ID, then you will be eligible for the free healthcare. Then people are just report and register birth whenever they has a baby. The second thing is that the development of the DRG, the case mix system, there is continuity research, and they reimburse or reimburse for the healthcare service, not just the capitation, but also with the DRG system. And this is the one thing that because DRG they use ICD-10, the ICD-9 procedure, and also need the standard data for the implementation. But at that time, the National Health Security Office and HSO also trying to create a lot of the beneficiary services, but they would like to know the statistic, and then they implement disease management information system, the outpatient individual record information system, but they didn't invest on the clinical data. They don't expand the data to include the clinical data like drug or lab or something like that. So those has a negative effect to the implementation of the health information system and health IT in the countries. We have more fragmented application. They just create application to serve their disease management information system. So the UHC also have positive and negative effect to the information system and health the health IT in the countries. So we are not perfect. Even we can have a claim system, use DRG, and can be control the budget. But you can see from the 3 dimensions of the universal health coverage, for reduce cost sharing or fee, government pay. So people are the Y axis will be almost 80-90%. No co-pay or the premium. And for the people who the population for the X axis, it cover 99%. But for the service, when first we implement universal health coverage, the anti-HIV drug are not covered. The renal replacement therapy like hemodialysis are not covered. So during these 20 years, they're trying to expand this service that they can serve. And you know that the technology is advancing. So there is more expensive, and there is a lot of old age. Then it's more and more require the budget. But the country still don't adding the budget quick enough. But the politician always trying to do the expand the benefits. The example is this last year, this new government just said, we will implement 30 baht treatment everywhere. Before that, if you are in the US universal health coverage, you have to have the gatekeeper. You have to go to the health center first, and the health center refer to the hospital. And if they are not capable, and then they refer to the secondary, tertiary hospitals, like this one, like the from primary care to secondary to tertiary. But they want to kind of the government just want to how can I say the populist policy, but they just expand the service, and they said right now they are going to have the 30 baht treatment anywhere, but the budget is not they don't have adding money enough to cover all the chain of the treatment and the prevention. So this is the news that the gold card or the 30 baht are risk for collapse. And you know what? A lot of protests this year, they just want to expand cancer anywhere. If you be cancer, you can go to anywhere. No need to the referral document, something like that. And you said one of the universities said that the National Health Security Office had made only partial payment for medical bill, but sometimes it's not paying at all. So they are, crying from the health provider, big hospital, small hospital, and clinics. Say that you are not paying us enough. And another thing is that there is no system to seamlessly integrated information from primary care, secondary care to tertiary care. So they don't know which treatment or which the condition that you already in the previous treatment, something like that. So another this is in Thai, but this is the protest from the university and big hospital and the clinic also said, you don't pay enough. And there is so many information application and information system that they are not integrated. The clinical data or the clinical for care, the data for care are not integrated and or cannot be exchanged. So you can see that we are not perfect, and this is the problems that we are facing now. Now I will show you that with the policy that 30 baht anywhere, they encourage the patient to go to the health center or health promotion hospital to get the drugs from the hospital, which means that you don't have to wait in line in the hospital. You just go to the health center, and then they will send the drug, your continuity of drug. The system will be send the drug to you. And this is the result of I'll just starting another one that they plan to do the telemedicine and they will pay for the telemedicine, and they said this will be minimize the workload for the health provider, which is doubtly that it minimize or not, but it will be easier for patient to get access. That is true. And this is the result of when you are the DM hypertension or the non-communicable disease, you don't have to go to the hospital. You just kind of the follow up at the health center or health promotion in the village, and they will send the drug to the health center or the health promotion hospitals, and they will dispense over there. So what do you see? You can see that the people who at the health centers sometimes has the kind of the error on dispensing drug, and this one, you see, in the label it's said that amlodipine 5 milligrams, but the actual drug that the patient get is amlodipine 10 milligrams. This happened actually happened because of the projects of the expand services, and then don't have the integrated seamless integrated health information and exchange between health center and also in the hospitals. This one is more severe. You can see that the label is metformin 5 milligram, but the drug is not metformin, it's another drug. Or the drug that giving the label said that is simvastatin, but the drug is enalapril. So this is a kind of the big issue on the health safety, and this is caused by what? Caused by there is no data exchange and integrated health information. There may be many loopholes in this workflow. Now you can see that all the three, the healthcare service, you can think of a lot of services. You can dream of the seamless healthcare services, but if you don't have the information to serve this healthcare service, the patient patient safety and quality care will be as the example that I just showed you. That is one of the example. And the protest of the provider that the National Health Security Office are not paying enough to cover the cost. So there is a lot of protest and also I mean cry out from the healthcare providers. I think everyone are familiar with the WHO health system, right? You can see the 6 building blocks. This is the kind of the input of the system, and we want the good healthcare service, responsible, and the UHC. That is the outcome or the outcome of the system. Among these 6, what I learned that if you don't design the healthcare delivery and also think deeply about how you're going to finance this kind of the services, and then have the information system that can serve for the financing and also for the good care service, it will not be possible that you will implement the success universal health coverage like Thailand too. Thailand are now, you can see that the development is that we just want to increase access. We developed the standard data for a little bit in 2 decades ago, but we don't expand it to the clinical data that we can serve for the seamless healthcare. But when we expand the service to kind of the go anywhere, then there is no infrastructure robust enough to serve this kind of the expansion of the healthcare services. And at the same time, if you don't have the reimbursement model is good, then the auditing, you cannot audit. And right now there is a lot of cry out, not just the not enough money, but also that you not pay correctly, and you cannot have the way to audit the healthcare provider that they cheat or not. So both financing and healthcare service need the good information system, the integrated seamless information system. For sure, you have to have healthcare worker and also the leadership and governance. So you can see that Thailand has been praised by many countries that we are success in the universal health coverage, but we are not quite sure. We still struggling with this, and this framework, if the three component, service, finance, and information system don't come and sit to design architecture, data standard, and also the financing model together at the same time simultaneously, then it will be very difficult to smoothly implement universal health coverage. That's why I conclude from my experience for the last 2-3 decades that if we want to success, or at least 3 of these health building blocks have to come on the same table, thinking how we gonna reimburse, what data that we need for claim system, what data we need for healthcare services, and how the claim system can manage the budget into kind of the not kind of the use all the budget like in the US, and how we're gonna expand the services to more and more to cover every disease. I call this the service information and finance frameworks, or the SIF frameworks. Thanks to Dr. Alvin, he just suggests that you should use the 3 legs for success of universal health coverage. Then I adopting his suggestion. So this is my framework. So the point is that you have to have all these at least three group of people to come and decide and sit together thinking through all of these 3. You cannot go linearly. You have to go simultaneously with these 3 design. So the critical lesson learned for me in the past 2-3 decades is that health service delivery, health finance, health information, these components must design and develop concurrently rather than in linear. And we need another 3 building blocks: human resource, material, and leadership and governance, for sure. So you can see that this is it's not linear like the first model. This is a kind of the model that I think should be represent the success of health system and universal health coverage. Incidentally, the SIF, when I search in the internet, SIF is kind of the name of the wife of Thor and the guardian of home, and she represents the this is the Swedish work law folk tales that she is the good mothers and the honorable God that can nurture the earth. So if you don't remember anything, remember Sif, the God, the mother of Thor, which is finance, information, and service, information, and finance model that you have to develop together. Now, if you read my papers, you can see that I look at some countries that they design all three together. One country is Taiwan, and they implement universal health coverage 15 years before Thailand, maybe 1980 something, 85, 86. And they also pay have their information system that they can do the audit like this one. And also every healthcare provider also send the same data, the same standard data to them. They implement citizen ID, and so they can do eligible who are eligible to what benefit. They pay by fee schedule of by line item, so they have a lot of detail on the item that they can pay, so they can do the price check for each drug, each procedures, and they also can gather the data and do the analysis, help both financing planning and also the healthcare service, and also inform the provider that okay, you are outlier, you are not very efficient on treatment on this. And this is one of their famous, the Taiwan National Health Insurance Medical. Right now, they said their service, it can go anywhere. What I heard is that if you are the Taiwanese, in the morning you cut cold, you go to one clinic, and then they will prescribe you the drug, the common cold drug and antibiotics. And then in the evening, when you go back, you not feel very good, and then you go to another clinic. The second clinic, they know right away that what drug that you got this morning, because of all the information are centralized at the National Health Insurance. So right now they have all the information and medical record, surgical record, examination, dental, medicine, rehabilitation, and they provide the My Health Bank or the personal health information that you can assess what service that you already use, what drug that you get, and what provider that you go. Provider also have those. Another example is the Estonia. When the Soviet Union break down, the Berlin Wall break down, and they independent for the Russian. They also building the digital or the eHealth, the X road. They have all the e-government services, SIL-TH, voting, and also several services include eHealth. And they are example of the centralized use the integrated standard for all e-government services. So this is the paper I just published with Dr. Supasit in the Health Journal of Health System Research. You can go and download on that. There is a detail what I just explained to you. What I will end up with this code. You can see that the interoperability between people and organization, that they have to work together, the financing people, the healthcare service and information, and also the governance, they have to come together and working together. The fragmented information, the cry out of the provider, the protest of the patient, because of all the authority or all the people who are working are not interoperable. People are not interoperable, but they just point out that, okay, right now, because of the data and are not seamlessly integrated. As uh, as many of you know that 20% is technical in data, 80% is people and organization. This is my reflection from my working in the past as the provider and also the informatician and also learning about health policy. What I learned that people just, the people who are responsible for health, ministry, organization, individual, they just say that they work for the people, but not. They work for their power. They just compete to gain the power. Sometimes when you collaborate, you have to give out your power to another stakeholder, but you don't want to give. You give out. You don't want to give away. Then it's not collaborative and work. It doesn't work. I would suggest many of you to look at the video clip from this link, and this is the final sentence that one of the actor in this clip said, that the first step to solving any problem is recognize there is one. The country should recognize that you have to come together collaboratively, and the three components have to work together and decide together. That is the message that I would like to convey to you. I will stop here and happy to get your question and discussion.
Thank you for presenting the SIF framework tonight, Dr. Boonchai. We would like to invite our participants to share their questions or maybe comments in the chat box, or if you wish, you could also unmute your microphones. But in the meantime, while we wait for questions and comments, maybe we can call on Dr. Alvin.
Thank you, Cha. Thank you, Dr. Boonchai, for this presentation. When you first presented this to the AHIN General Committee, I thought that this was really very timely because of the simple, SIF, very easy to remember, even shorter than GAPS, only 3 letters. And I thought that it would be very important for the network to learn more about the SIF framework and why they need to be dealt with together. You cannot just offer services without collecting standardized information, and you cannot just pay for services without really setting up a robust information system. So by having this triangle of SIF, we are sending the right signal to our governments and to our national health insurance agencies that they need to think about this three-legged stool, this triangle, altogether, not one without thinking of the other. I also appreciate the sharing about Taiwan and Thailand. I think your national ID system is the one that is common because you had a very strong and robust national ID system. It was easier for Thailand and Taiwan to count. How many people do we have and how much money do we need to make sure that we provide universal health care to everyone, including the vulnerable and the marginalized. The Philippines has been and is still struggling with our national ID system. I hope that it's better now than 5 years ago or 10 years ago when I was at PhilHealth. We didn't really have any clear count of the number of Filipinos in the country. And so it was very difficult to come up with financial models and also to predict how many human resources and infrastructure we need to address the needs of our population. But I think today we are now at 85 to 90% adjourned on the people with national and digital identifiers. So with that, I think we should open the floor now to the audience, just to congratulate and thank Dr. Boonchai for sharing this framework. I encourage everyone who is interested in SIF, we will continue to talk about this. If you think you want to form a group chat or a special interest group around the SIF framework, just let us know and we will set it up. Thank you. Back to you, Cha.
Yes, thank you, Dr. Alvin. We have our first question in the chat. It's from Dr. Aminul Islam. So, Dr. Boonchai, could you explain the concepts of the three-legged stool model?
Yeah, the concept of the three-legged stool is that you have to balance with the three legs. Thailand is a good example. We just keep expanding the services, and then we don't invest much on implementing the information system. For example, if you want to know, if you want to know who pay drug, which drug that you use for healthcare and also for the reimbursement, you don't have to have the standard coding system of the drug. You know, in 2011, they recognize that they don't have this what I mean, the insurer and the Ministry of Health and also the policy. They want to know how much, how much they have to pay. The system have to pay for the medication, which is mostly 40% for the inpatient and 70% for the outpatient. And how big, and the budget for the medicine is, I mean, the expand. And then at the time they asked me, and they asked they asked me to develop the national drug code, and we developed TMT, Thai medicine terminology. At the time, I said, oh, this is a very good coding system, and we can identify the product. It spent 6 months, only 6 months, to come up with the model and also just accumulate the registry. But it takes 10 years for change for the National Health Security Office to implement TMT for their claiming system and also the others. Right now, you can see that if you expand, but you do only one system and you don't do another system, what I just tell you, my struggling in the past 15 years to implementing the national drug code, the TMT. They don't care. So they don't care to promote and also work on integrated the claim and other service or on the with the information. Then it's not stable. It will fail. Right? Thailand now is still struggling with this. That's why we are now trying to say we have to use gaps, governance, architecture, people, and standard and interoperabilities. We would like the country to adopt SNOMED CT, which will be you will know exactly what service that you provide, what procedure you do. We are implementing the Thai medicine laboratory terminology, and it still takes time. But to be honest, I voiced these many years, but the political, the government, they see that this is a technical thing, but it's not. you need to have more resources, have to finance, and it's a lot of work to not just getting technical thing. You cannot buy it. You have to train to have people to developing this and also integrate it into the healthcare service and the financing system. So the three stool is that it should be balanced.
Thank you, Dr. Boonchai. We have a question as well from Dr. Alvin. So what is the role of SNOMED in SIF?
You know, you can see that the ICD is for the statistic. The SNOMED is for the electronic medical record. And when you do the services, the electronic medical record serve your workflow, serve your the detail that you will do that. And how we gonna represent what we have we work on the healthcare service. ICD cannot represent those. It the kind of the group of the disease for the statistic, and the way that the ICD structure is the classification. There is no relationship of the term. That's why if you want the detail for seamless for the clinical data, SNOMED CT is the answer. Each semantic standard need have their functions. SNOMED ICD is important for the statistic and also for the administration, right? The claim system to create the DRG, to calculate the DRG. But if you want to describe what you are working, doing at the point of care, semantic code like SNOMED CT is needed to be able to do the seamless healthcare services, to have the EMR healthcare information system between provider speaking the same language.
Thank you, Dr. Boonchai. Our next question is, how does Thailand assign cost or financing behind each service? And are the DRGs part of this?
Yes, this is a very good question. You asked about how we gonna do the finance or reimbursement model, right? Should we do capitation? Should we do the fee for service, or should we do the fees, what they call fee schedule, or the case mix system? All of those need information, need data. If you want to know the cost, then the more detail of the resource that you use will be very important. How to represent the cost. If you want to know the detail of each drug that has been used, how many of these disease or these symptoms utilize drug as the average, what procedure about this group to calculate the DRG. So the DRG is two parts, right? The classification part, the grouping part, and the costing part. So to answer your question, this is the good example that you have to do three together: service, finance, model, and also information. And information serve service and also finance. And the finance also make it incentivize people to correct data. People don't change if they know money.
Dr. Boonchai, our time is almost up, but we still have two questions. I hope we can entertain this. So the second to the last question is from Dr. Sir Keith Duddy from Anzil. So how different is the availability of services in the regions compared to the cities, even if everyone has universal insurance?
Oh, in Thailand, this is one thing that important about the service delivery system component. 50 years ago, the country invest on building every hospital in every district, and also build a big hospital in every province. And also every village will have at least one health center. Right now, we have a network of healthcare services. We have more than 10,000 health centers across the countries, both rural and urban. We have 700 something community health community hospital, or the secondary hospital in every district. Some districts have more than one. We have 96 provincial and regional hospitals. We have 15 medical centers. All of these are the network of the healthcare services. True that in the mountain, in the very far, it still have a problem, and we have also problem on the distribution of the healthcare provider. People don't want to go to the very rural area. Doctor right now the doctor at the border, which is a very have a lot of works. They are just moving to the cities. But this is the example that the healthcare service delivery system, you have to build the infrastructure, hospital, provider in all across this.
Thank you, Dr. Boonchai. We have 1 minute left in the session. So what is your advice to countries who are just beginning their UHC journey?
To me, I think you have to have 3 people, or if you are the information guy, you have to working with the financing guy and also the health policy and healthcare service. Don't do it linear. Don't do it linear. Don't do it linear. That's what my Thailand, you see, it's people are kind of praise that Thailand success in the UHC. If I don't tell you about our problem, how are you going to understand our problem right now? We are not perfect. The point, the key message is that these 3 components you have to do simultaneously, not one by one.
Yes, thank you, Dr. Boonchai. We would also like to thank all our participants for attending this session and sticking with us through the end of the session. All right, thank you, everyone.
Thank
Thank you,
you.
Cha.
Bye.
Thank
Thank you
you.
very
Hi,
much.
Merrick. Hello,
Thank you.
everyone.
Thank you, Cha.
Bye-bye.
Good to see you
Thank
all.
you, Boonchai.
Bye.